Smita, we need to start now, please.
Shall we start, Asmita?
Yes, go ahead, Ganvi.
Good evening, one and all. We welcome you to another episode of the Wednesday special thyroid clinics organized by the Indian Thyroid Society, which is equivalent to a knowledge fest. So before we begin, let us just go briefly through the journey of the Indian Thyroid Society. So Indian Thyroid Society was established and registered in 2003. It is a national body of healthcare professionals with special interest in thyroid disorders. It includes endocrinologists, endocrine surgeons, nuclear medicine physicians, general surgeons, and ENT surgeons. ITS is a member of the Asia-Oceania Thyroid Association, that is the IOTA. ITS currently has nearly 2,000 members. So in the executive committee, we have the founder president, Professor R.V. Jaikumar sir, the present president, Professor Sarita Bajaj madam. Also past president, Professor Rajesh Ratput sir, the current secretary, Dr. Arun Menon sir, the treasurer, Dr. Mini G. Pillai ma'am are also members of the executive committee. Dr. Himagirish K. Rao sir is the vice president. The scientific committee coordinator is Dr. Pramila Kalra madam. The joint secretary is Dr. Sujay Ghosh sir. Also, Dr. Shashank Joshi sir, Dr. P.K. Jabbar sir, and Dr. Krishna Shishadri sir. Dr. Mohammad Riaz, Dr. Sushil Gupta sir, and Dr. Ashraf Jani are also members of the executive committee. So the aims of the Indian Thyroid Society is to organize academic activities for healthcare professionals, to promote public education and awareness about thyroid disorders, to encourage research in thyroidology, to encourage publication in the flagship journal, that is Thyroid Research and Practice. It is also to have the state-of-the-art publications. Also, one of the aims is to award fellowship of the society and to encourage membership of the society. So the ongoing academic activities by the Indian Thyroid Society are the CMEs, the updates, the symposia, and the conferences. Also, the thyroid clinics, which were being held weekly prior and presently being held fortnightly, include journal clubs, case conversations, monologue, geologue, panel discussion, meet the professor session, quiz, workshop, as well as CPCs. So the programs undertaken by the Indian Thyroid Society are the Thyroid Awareness Week, which is celebrated between May 22nd to May 28th, the World Thyroid Day, which is celebrated on May 25th, and the Thyroid Awareness Month, which is celebrated annually in the month of January. So the research activities undertaken by the Indian Thyroid Society is to provide annual grants for original research studies focused on thyroid and other related disorders, preferably in the Indian context. The research grants are available, so it can be accessed in the following website, that is the indianthyroidsociety.in. Also, the Indian Thyroid Society has its own journal, that is the Thyroid Research and Practice, which is published twice a year in print and online. It has a quick turnaround time. The electronic copies are available ahead of print. So Indian Thyroid Society also awards fellowship. It is basically awarded to the ITS members who have expertise and experience in the field of thyroidology. It will be selected by an expert panel, and the eligible members will be conferred the Fellow of Indian Thyroid Society. So there are numerous publications also by the Indian Thyroid Society. That is the ITS Clinical Manual of Thyroid Disorders, the first edition, the editor of which is Professor R.V. Jaikumar sir. Also, numerous guidelines have been published by the Indian Thyroid Society, like the Thyroid Dysfunction in Pregnancy, Guidelines for the Management of Thyroid Dysfunction During Pregnancy, Hypothyroidism and Diabetes. Also, other guidelines like consensus statements on the management of subclinical hypothyroidism, guidelines for the management of dyslipidemia and thyroid dysfunction, guidelines for the management of depression and thyroid dysfunction have been published by the Indian Thyroid Society. So the upcoming publications of the ITS are the ITS Clinical Manual of Thyroid Disorders, that is the second edition. The chief editors are Dr. Professor Sarita Bajaj madam and Dr. Rajesh Ratput sir. There are numerous upcoming guidelines also in the pipeline, which will be published in the year 2022 and 2023. They are the management of subclinical hypothyroidism, management of thyroid disorders in pregnancy, management of thyroid carcinoma. Also, Indian Thyroid Society has its own website, which can be accessed by the link that is the indianthyroidsociety.in. It has numerous contents like the link to the guidelines, access to ITS journals, records of all the academic events. Online membership portal is also available on this website. So Indian Thyroid Society awards membership as well. All MCI registered modern medical practitioners in India are eligible to become life members. Basically, two types of life membership are awarded. So the full life membership is basically awarded to the specialists in the field of endocrinology, endocrine surgery, and nuclear medicine, whereas the associate life membership is awarded to all the other registered medical practitioners. So the applications for the membership are invited online on the ITS website, which can be accessed on the following link, that is the indianthyroidsociety.in. So before we begin, let us have the quiz participation rules. This helps the participants to begin to log in their answers much more easily. So the IT team, can we display the quiz participation rules, please? Yeah. So to participate in the quiz, having a Zoom app on the mobile device or laptop is essential. You are requested to use a laptop for the ease of experience. The quiz will run for about 10 minutes. There will be first 2 dummy questions followed by the actual quiz. The quiz master will display the case or description of the quiz by screen sharing a PowerPoint file. The participants should use the polls option to participate in the quiz. All the 10 questions will be available when the poll is launched, and answer for all the questions is to be submitted at once at the end of 10 minutes. To read the case or description, you can close the polls using the X button and again use the polls option to answer the respective question. So can we have the dummy questions? Asmita, can we have the dummy questions, please? Yeah. So the first question is, in which city is Taj Mahal located? So option A, Chennai, option B, Mumbai, option C, Agra, and option D, Bangalore. The second question, how many oceans are there? Option A, 8, option B, 5, option C, 6, and option D, 7. So hope all the participants eager to participate in the quiz could log in their answers. So the Indian Thyroid Society Thyroid Clinics webinar is being conducted under the leadership of the foremost esteemed conveners, Professor Sarita Bajaj Madam, who is presently the President of the Indian Thyroid Society, Dr. Pramila Kalra Madam, who is presently the Scientific Coordinator, Dr. Arun Menon sir, who is the Secretary of Indian Thyroid Society, and Dr. Miniji Pillai ma'am, who is the Treasurer of the Indian Thyroid Society. So today's programs basically will be chaired by Dr. Naresh Bansal sir. The first session will be a dialogue on thyroid disorders in pregnancy by Dr. Vikram Shekhawat sir and Dr. Amit Nachankar sir. This will be followed by the quiz by Dr. Shaila madam. And following this, there will be the monologue on thyroid and more by Dr. Amrish Mittal sir. So following this, Dr. Shaila madam will discuss the answer keys and the winners of the quiz will be announced. So let us start the first session by welcoming our distinguished chairperson for today's session, Colonel Dr. Naresh Bansal sir. So can we have Sir CV? So Sir is presently the head of the Department of Endocrinology at Command Hospital, Pune. Sir has done his DM Endocrinology from Command Hospital, Pune. Sir has done his MD Medicine from AFMC, Pune. Sir has done his DM from BHU, Varanasi, and Sir has done his MD Medicine from AFMC, Pune. Sir has about 10 publications and 6 chapters in various books. And Sir has also authored about 5 PG textbooks. So I would like to ask Naresh Bansal sir to say a few words and introduce the speakers for the dialogue session. Over to you, sir.
Thank you, Dr. Ganavi ma'am and Professor Dr. Sarita Bajaj ma'am for giving me an opportunity to share this session. In fact, it has been a great initiative and a commendable effort by Sarita Bajaj ma'am, and it is helping the clinicians, the residents, and the physicians who are actually passionate about treating the thyroid disorders. All the facets of the thyroid disease, from clinical to molecular medicine and genetics, has been discussed by stalwarts in the field of endocrinology. This truly interactive format of the sessions is helping everyone in developing a scientific approach in solving the diagnostic conundrum. Today we have a duologue followed by the quiz, and thereafter we have the monologue. The initial duologue will be done by Dr. Vikram Shekhawat and Dr. Amit Nachankar. Dr. Vikram Shekhawat is the head of the Department of Army Hospital Research and Referral at Delhi Kent. He has done his DM endocrinology from PGI Chandigarh, and he's a very dynamic endocrinologist and has numerous publications to his credit. And Dr. Amit Nachankar, he's done DNB endocrinology from Army Hospital Research and Referral. He's the associate professor, Department of Endocrinology at Army Hospital. He's also the faculty for online teaching program by National Board of Examinations. He has numerous publications in national and international journals. Now I'll request Dr. Shekhawat and Dr. Amit Nachankar to please start with the duologue. Dr. Amit will be presenting the cases of hypothyroidism in pregnancy, while Dr. Shekhawat will be presenting thyrotoxicosis in pregnancy, and they will be both discussing. All the participants can participate in this duologue as well by giving their questions in the chat box. Over to Dr. Amit Nachankar first.
Sir, should I? This is Colonel Shekhawat.
Dr. Shekhawat, you can do it first. Please share your screen.
Is it there, sir?
No, we are not able
yet.
to.
But my voice is clear, sir, is it?
Yes, I
Voice is
think we
clear.
can hear
Your
you.
voice is clear. Your voice is clear.
Yeah, absolutely. Who was able to share their screen earlier?
Dr. Amit, you can present the cases first.
Amit, are you there?
Yes, ma'am, I'm there.
Please go ahead.
Sir, I think I can share my. Can you see my screen, sir?
No, not yet. No.
But my video is visible, is it?
No,
Yeah,
nothing
video is
is-
visible.
Yeah, of course you are. Yes, he's visible.
We can hear you also. We can see you also, but the screen we are not able to see.
Okay, ma'am.
Maybe
Then I
you
guess
can stop share and try again. Once you stop share and try again, it will come. Sometimes that happens. Like you can just, if you are sharing, you can stop share and do it once more.
Yeah.
Then it will come.
Dr. Amit, you can start with the session then till the time is sharing.
Great. That's good. That's good. We can see you, but you have to do a slideshow.
Can you hear me, sir, or should I start, sir?
Yeah,
Yeah,
you
please
please start
start.
it.
Please
Sir,
Please
you
start.
are PowerPoint
Keep your
still in
slide
editing
show.
mode.
Okay, good evening, everybody.
That's fine.
It's a wonderful opportunity that I am going to present the thyroid hypofunction in pregnancy. Actually, since I was supposed to present second time, I have not covered the initial physiology part of this presentation. And I shall be discussing maternal thyroid hypofunction in the form of pre-pregnancy screening and early pregnancy screening, what is appropriate. Then the disorders can be diagnosed either during pregnancy in the form of subclinical hypothyroidism or isolated hypothyroidism during the pregnancy screening, or it can be presented as the overt hypothyroidism first in the pregnancy. However, most of the cases, patients may be having known case of hypothyroidism, either overt or subclinical, and they present in the pregnancy on the existing dose of levothyroxine. So the maternal thyroid from hypofunction, the risk factors being the old age at the presentation of pregnancy, other presence of other autoimmune diseases, multiple gestations. The causes are similar to what they are there, basically Hashimoto's thyroiditis or post-ablative or post-surgical hypothyroidism or severe iodine deficiency. Being a hypofunction, the symptoms may be hypometabolic, but in cases of subclinical hypothyroidism, they may not have any symptoms. And signs will be typically of the hypometabolics, like there will be goiter, dry skin, thin hair, and in view of pregnancy, there will be relative bradycardia as compared to overt bradycardia as we see in the hypothyroidism patients. So the prevalence has been detected to be around 0.5% of overt hypothyroidism and 3.5% in subclinical hypothyroidism. And only isolated hypothyroidism is seen in around 2.1%. So I'm describing a case with a 26-year-old female referred for thyroid function at 8 weeks of pregnancy. She was absolutely asymptomatic, and her thyroid functions were TSH of 8.1 micro international unit per ml with free T4 of 0.99 nanogram per deciliter, and anti-DPO antibody was positive. So this is a straightforward case. In view of her family history of autoimmune thyroid disease, we have obvious diagnosis of subclinical hypothyroidism in the early pregnancy. Now comes the role. Is it appropriate to screen the patient in the initial part of pregnancy, or should they be screened prior to the pregnancy? So there are various guidelines have been said. AAC guidelines in 2002 has said that you can screen with TSH even in pre-pregnancy and first trimester. However, over a period of years, the guidelines have evolved, and they have in the 2012 guidelines, they said you can do the testing with TSH only, no need for free T4. And the last guideline, which was given in 2017 by American Thyroid Association, has also said you should go only screening as a targeted in high-risk groups, and that too as a TSH form only. And if the TSH has come elevated, you have to go for the TPO antibody as a reflex factor. If the TSH is suppressed, suggestive of hyperthyroidism, you should go for free T3. But since I am presenting here hypothyroidism, hypofunction part, so there are certain high-risk populations has been said by ATA in the guidelines, like underlying history of hyperthyroidism or previous hypothyroidism, or age more than 30 years, presence of anti-TPO antibody positive for some other disorder, or underlying other autoimmune disorder like type 1 diabetes, obesity, and use of certain drugs like amiodarone or lithium, or patients who are staying especially in the severe, moderate to severe iodine deficiency areas. So there was the initial article which has shown in 2012 regarding by the New England Journal of Medicine, which said that antenatal screening has not resulted in any improved cognitive function if it is such patients with levothyroxine dose. Now, before going to the thyroid hormone and fetal CNS effects, I have not covered the initial physiology part because it was supposed to be covered in the previous lecture. So I can tell one thing, that with the thyroid hormone, the effects which are more on the, not only on the maternal part, but also in the fetal part. And the thyroid ranges which are there in non-pregnant patients are ultimately different altogether from the pregnant patients. Because in the first trimester, there is reduction in the TSH level by 0.5 in the upper range and by 0.4 in the lower range. So the lower part is considered as 0.1 micro international unit per minute, and upper limit of normal is comes to be 2.5. Whereas in the second and third trimester, it is slightly higher, that is up to 3 micro international unit per ml of the TSH upper limit. So this TSH upper limit has to be considered unless we have got the population specific reference ranges available with us. So considering this, I'm going to discuss what are the thyroid hormones responsible for the fetal CNS effects and why they are important during the pregnancy to have optimum level, basically below the 2.5 micro international unit levels in the first trimester and below 3 in the second and third trimesters. The reason being the fetal thyroid, which is there, which starts developing at around 12 weeks of pregnancy. So up to initial 20 weeks of pregnancy, you require support thyroid hormone supply from the mother. And it is important for the neuronal proliferation, which occurs in the initial part, as well as in onset of neuronal migration, which also occurs in the initial part, and it completes by around 16 weeks. So the fetus does not have underlying thyroid hormone per se up to 16 weeks. And from 16 to 20 weeks only, it starts producing the thyroid hormone, and which gradually increases in third trimester, if you can see. So it is important for mother to be euthyroid, basically normal, not only the TSH level, but also the free thyroid hormone levels. And it has been seen that the optimum development of cortex occurs when there is maternal free thyroid hormone in the optimum level. If it goes below the lower limit, that is thyrotoxic, then also the cortex volume reduces and the child's IQ also reduces. Whereas if the patient is treated in the higher dose, then the free thyroid hormone increases, and also it has shown to reduce the IQ as well as the volume of the cortex, which develops over the period in the gestation period of 36 to 40 weeks intrauterine life. So it is important that these neuro effects has been studied in the article in 1999, and it has said that the significant effect of maternal hypothyroidism occurs on the neurodevelopment. And they have seen that there is 4-point lower IQ between 7 to 9 years in the children of hypothyroid mothers. And when they removed those children of hypothyroid mothers who were on treatment and compared to the euthyroid patient versus those who were hypothyroid but not on treatment, there was an IQ difference of almost 7 points was seen. So this is the important effect we should know regarding the euthyroid status, which should be available in the mother, so that optimum neurodevelopment occurs. There have been initial few studies which were done in 2008 by Clary, Goldman et al. Has not shown any significant association between maternal hypothyroidism, subclinical hypothyroidism in first or second trimester versus adverse pregnancy outcomes. And in 2015, there was another meta-analysis had come of 10 cohorts that also did not show any significant association between maternal subclinical hypothyroidism and preterm burns. However, there was another study has come in 2014 from the Chinese group by Liu H, which said that if the subclinical hypothyroidism with TSH of 5.2 to 10 is there is increased pregnancy loss of 3.4 times compared to those women who has got TSH of less than 2.5 million international units. And these are certain pregnancy outcomes they have shown, basically the pregnancy loss, preterm delivery, gestational hypertension, preeclampsia, gestational diabetes, placental aberration, premature rupture of membranes. Everything was higher except preterm level and placenta previa. Also, there was increased incidence of cesarean delivery was seen as a maternal obstetric outcome. Whereas the fetal outcomes, when we consider, there was increased incidence of IUGR, low birth weight. At birth, there was low Apgar score, and patient presented with small for gestational age. Also, there was significant increased relative risk of neonatal death, which was seen in the meta-analysis by Merca et al. And in 2017, there was another landmark article came in the New England Journal of Medicine, which said that the treatment of subclinical hypothyroidism or hypothyroidism, if it is done between 8 to 20 weeks, did not have shown any better cognitive outcomes in the fetus. So it is better to have the early replacement of thyroid hormone as early as possible so that the euthyroid status is maintained for the neurodevelopment of the fetus. There were 3 studies. Earlier, the study that I had shared, this was by Casey et al. In 2017. Before that, there was controlled ACT study, that is controlled antenatal thyroid study, which was done in 2012, in which they had used, even in patients of subclinical hypothyroidism, very high dose of levothyroxine of 150 micrograms per day. And they also shown that there was no benefit with regard to IQ because the onset of treatment was done at the beyond 12 weeks of gestation. Whereas in 2018, there was a study by Nazarpour et al., which had shown that the screening was done slightly earlier, that is between 11.4 weeks. And they said that if we treat the subclinical hypothyroidism with levothyroxine in optimum dose, it may reduce the preterm delivery, especially when the subclinical hypothyroidism presents with TSH more than 4. So there is no specific guidelines which says that between TSH of 2.5 to 4, in the absence of anti-TPO antibody, or even in the presence of antibody, the role of any treatment is there. So coming to this study in Lancet Diabetes by Correva et al., they said that if we treat subclinical hypothyroidism, there is U-shaped association between response to the fetal IQ at 6 years. Like if the free T4 maternal T4, free T4 is low, that means we are treating subclinical hypothyroidism inappropriately or not treating it. Or in the opposite arm of U, where there is high free T4, and then also there is affection of the neurodevelopment. And so we have to have optimum free T4, which should be in the range apart from the association of hypothyroidism. And this study has said there is no association of fetal neurological effects with the maternal diseases, and it mainly correlates with the free T4 hormone levels. So it is important that we should avoid the low thyroid hormone exposure in utero because it has been shown to affect the neurodevelopment adversely. Now coming to the dose of levothyroxine therapy in antenatal care. They say that initially, arbitrarily, the dose used to be there between 4 to 8 TSH of between 4 to 8. They used to give 25 to 50 micrograms of levothyroxine. However, in the recent article published in Endocrine Practice in June 2022, they said that the dose should be up to 1.35 microgram per kilogram of maternal pre-pregnancy weight. And levothyroxine only should be used. There is no role of LT3 or combination of T3 and T4 because these hormones, T3 or T3 and T4 hormones, if you use desiccated thyroid hormone, it does not cross the placenta. So the only hormone, that is the monotherapy of levothyroxine, should be used. And when we are using it, we have to monitor thyroid function test every 4 weekly up to the 20 weeks part. And beyond 20 weeks, then the usually thyroid hormone, if it stabilizes, if we maintain the target of pH less than 2.5, then we can again do the thyroid function test at about 30 weeks. Now coming to the second part, that is the isolated isolated hypothyroxanemia in pregnancy. There are a number of risks have been associated with these things like iodine deficiency, certain environmental pollutants, obesity, certain placental angiogenic factors like placental IGF or soluble FMS like tyrosine kinase 1 factors, which have been associated with maternal isolated hypothyroxemia. That means there is normal TSH, but free T4 level will be low. And what are the effects of this? There is increased risk of premature rupture of membranes, low birth weight child, less. But paradoxically, even though there is increased risk of low birth weight child, fetus, there is less incidence of small for gestational age in the cases of isolated hypothyroidism, and has been shown to increase the incidence of macrosomia also. So there are conflicting literature about this. But the only effect which has been consistently proved in various studies is the presence of isolated maternal hypothyroidemia is associated with preterm delivery. And this preterm delivery, if the isolated hypothyroidemia present in only first trimester and not in second trimester or beyond. There is also conflicting reports whether to treat isolated hypothyroidism in pregnancy or not. Some say that if there is previous history of fetal loss or anti-TPO positive, consider LT4, that is levothyroxine, 25 microgram per day, and monitor thyroid function test 4 weekly. However, ACOG guidelines does not mention anything about treatment of isolated hypothyroidemia in pregnancy. It is only the ATA guidelines and AAC guidelines which are mentioning the treatment that to consider option and not must option for the maternal isolated hypothyroidism. Coming to the overt hypothyroidism in pregnancy, in this case, the patient may be pre-existing hypothyroid and on levothyroxine dose and come in the pregnancy without screening pre-pregnancy, or it is detected first time during the pregnancy. So there are a number of antenatal complications have been mentioned with overt hypothyroidism. Maternal implications like PI, preeclampsia, bruptioplacenta, increased miscarriage rate, increased risk of cesarean section, and postpartum hemorrhage have been mentioned. Whereas the fetal complications are also there, like preterm delivery, low fetal birth weight, increased perinatal morbidity, increased fetal and prenatal mortality, and neuropsychological and cognitive impairments have been shown. And these complications, especially obstetric complications, have been seen significantly with the overt hypothyroidism patient as compared to the subclinical hypothyroidism patients.
Amit, may I request you to go to the cases and be slightly fast?
Sir, I have discussed only single case, sir, that is the hypothyroidism, that case vignettes. And I'll be finishing within next 5-6 slides. So it is important to know the treatment of overt hypothyroidism in pregnancy. So if overt hypothyroidism is present without knowing prior to the pregnancy, it is important that the lady should plan the pregnancy because there is increased demand during the pregnancy. And once she suspects pregnancy or there is confirmed pregnancy, either she should consult a doctor, or if pre-pregnancy there, it is better to control the thyroid hormone levels in the doses that it comes between 0.3 to 2.5 pre-pregnancy. And because it is important that the thyroid hormone requirement increases in first trimester by 20 to 30%. So we should, in pre-pregnancy status, while screening, we can guide the lady that in case she becomes pregnant at home pregnancy test, it's better to take 2 extra tablets of the current dose of levothyroxine. And then she should come to the visit to the concerned specialist for the follow-up. And if the diagnosis occurs during pregnancy, then we know that the complications are more. So it's better to start the levothyroxine monotherapy at a higher dose, that is between 2 to 2.4 microgram per kilogram per day, as compared to the normal 1.6 to 1.8 microgram per kilogram per day dose that we use. And here we do target the TSH as per the trimester specific range, that is below 2.5, unless we have trimester specific reference data for the local population available. Regarding T3, I have already mentioned that there is no role of treatment with LT3 or combination of T3, T4 or desiccated thyroid.
Amit,
So
just a question here. You know, we frequently find that a lot of females come with the question that, you know, since we have such severe degree of hypothyroidism and the risk associated with it for the fetus, should we terminate our pregnancy or not? What advice will you give to such patients?
Yeah, I mean, often we come to know certain patients are referred for gynecology in the first trimester with very high TSH, that is between 50 to 60, because they were not initially screened in earlier, and they come with the pregnancy with overt hypothyroidism. In such case, there are no proper guidelines mentioned in the literature, and they have not demonstrated that there will be effects on the maternal outcome and fetal outcome. So always it is important for us to explain to the lady that these effects are possible in the pregnancy, like effects PIH, eclampsia, abruptio placentae, etc. And preterm delivery, requirement of increased LSCS, as well as fetal effects like fetal neurodevelopmental delay could be occur, low birth weight may occur. So such kind of ladies should be explained the prognosis of future pregnancy. However, we cannot guide them regarding the decision that you should terminate or you should not terminate pregnancy, because that is the decision of the lady herself. So coming to the
I'm sorry, we have to, because see, there are two presentations.
Just two
We have to
slides,
finish
ma'am.
within 40
I'll be
minutes.
finishing next two slides only, ma'am.
But there is, anyway, I don't know where is the case.
So the case was the initial one with the patient, a lady presented at 8 weeks with the subclinical hypothyroidism. So after discussing with literature on the subclinical hypothyroidism, it is obvious that we should treat as per American Thyroid Association guidelines. Since the lady has got TSH between 2.5 to 10 and TPO antibodies positive, we have to consider the treatment with levothyroxine therapy basically. And she should be every 4 weekly, the thyroid hormone should be, TSH should be checked till the 20 weeks of pregnancy. There is no need for monitoring unless the pregnancy has underlying other causes which requires monitoring. Only thyroid hormone monitoring is required, basically. So I shall be completing my presentation with the take-home message that it is important that we should interpret the thyroid function test as compared to the gestational age of the lady in pregnancy. We must treat over hypothyroidism. There is a role of whether to treat subclinical hypothyroidism beyond 10 if the TSH, or if the anti-TPO positive and TSH more than 4. And always we have to ensure that the thyroid function test dose is increased by 20 to 30% per weekly dose. And when the patient comes with the overt pregnancy, with target TSH to be maintained below 2.5 in first trimester and below 3 in second and third trimester. And no, there is no role for LT3 or desiccated thyroid hormone levels. Thank you.
Dr. Amit, if the patient is only anti-TPO positive, how do we follow up this patient? If the patient has normal thyroid profile but only anti-TPO positive, patient comes with the report of anti-TPO positivity, how do you interpret this report and how do you explain it to the patient?
The presence anti-TPO repeat, as per the guidelines, you are not supposed to do anti-TPO test if the TSH is in the norm below 4, basically. If TSH is more than 4, then only you have to do anti-TPO test, unless the patient is overt hypothyroid and on treatment prior to the pregnancy. So there is no role of anti-TPO testing done, no role if the TSH is less than 4 at the initial screening time.
Thank you, Dr. Amit. Ma'am, any questions from your side?
Yeah, we have a question in the chat box. Can you see that?
How do you
Harish?
diagnose diagnosis of isolated hypothyroxemia? Dr. Srinivas wants to know.
Yeah, isolated hypothyroxemia is diagnosed with normal TSH to the trimester-specific range with low free T4 hormone levels. In case people are, the total T4 is used, it is important to know that in the pregnancy, from 7 to 16 weeks, there is 5% increase in the total T4 level per week, so that it increases 50% above the normal pre-pregnancy range by 20 weeks. So it is important that we have to calculate the upper margin of total T4 for that gestational period when we are considering the isolated hypothyroxemia, and the lower level of free total T4 should be the concern as per the laboratory specific range. So isolated hypothyroxemia occurs when the TSH is normal, but the free T4 is below the normal limit for the trimester specific range.
Thank you, Dr. Amit. May I now request Dr.
Thank you, sir.
Shekhawat to please share his screen.
Yeah, but we have just 9 minutes left.
I'll request Dr. Shekhawat to please hurry up so that we finish off in time. Dr.
Yeah,
Shekhawat,
9
please
minutes.
start
We
your
just have 9
presentation.
minutes, I'm sorry.
Dr. Shekhawat, you can start your presentation.
Just a minute, sir. Are my slides visible, sir?
Yeah, your slides are visible.
Can we just go to the case and discussion, please?
Hello.
If there is
Hello.
any case for discussion.
Hello, Dr. Shekhawat.
Dr. Shekhawat, we can go to the case.
Is there any case for discussion?
Yeah.
Hello. Hello.
I think what we'll do is we'll do the quiz and we'll move on to the talk by Amrish. And then we can come back to Dr. Shekhawat later. Ganvi?
Yeah, ma'am, I think
Yes,
this is better.
ma'am. Yes,
We can
ma'am.
look
We'll
at it.
move on
Yeah.
to the quiz, ma'am.
Yeah, we'll go on to the quiz and then, hello, Shaila. So you can just tell
Yes,
the
ma'am.
rules once. So the participants you have logged in later. Can we, Smita, are you okay with that? Thank you. Perfect. No, but
Yes, ma'am.
yeah.
Thank you, Dr. Amit, for a very interesting discussion. So moving on, I request Dr. Naresh Bansal sir to introduce the quizmaster for today's session, Dr. Shaila ma'am.
Dr. Shaila Sheikh is a well-known endocrinologist. She's a consultant endocrinologist at Prince Ali Khan Hospital and Safai Hospital and Wokhart Hospital. She's a principal investigator in about 34 international clinical trials, and she's a executive member of Endocrine Society of India. It is really very knowledgeable to listen to Dr. Shaila. She will be presenting the quiz today, and all the participants can actively take part in it, and they can also win the certificates and the awards at the end. Over to Dr. Shaila.
Thanks, Dr. Bansal. Thank you, sir, for the very kind introduction. And it's an absolute pleasure being over here. Thank you, ma'am, for inviting me, Pramila, for inviting me, and of course, Ganvi, for tolerating all my late messages. She's been an absolute angel during this entire process. So big thank you to you too, dear. To be honest, while making this... Sorry.
Dr. Vikram, we can present it. You can present it later on. Let the quiz go on.
Dr. Shekhawat, we'll do it after Dr. Mittal's talk, your talk.
Yeah, absolutely, absolutely.
Yeah.
Okay.
To be very honest, it was a learning experience. And thanks to Sarita Bajaj ma'am for asking me to do this quiz, because I had to do a lot of reading to actually to make the quiz. So it was a fantastic learning experience. My first time as a quiz master, to be very honest. So I'm going to take this directly to...
Ma'am, we start with a dummy with... Hello.
We're going to do the
Yeah,
dummy
we want to
questions.
dummy questions first. Yeah, dummy questions.
Then I'll stop sharing.
So we'll go through the quiz participation rules again, just to repeat. So Asmita, can we have the quiz participation rules, please? Yes, to participate in the quiz, having a Zoom app on your mobile device or laptop is essential. You're required to use a laptop for the ease of experience. The quiz will run for about 10 minutes. There will be first 2 dummy questions, followed by the actual quiz. The quiz master will display the case or description of the question by screen sharing a PowerPoint file. The participants should use the polls option to participate in the quiz. All the 10 questions will be available when the poll is launched, and the answer for all the questions is to be submitted at the end of 10 minutes. To read the case or description, you can close the polls option using the X button and again use the polls option to answer the respective question. So we'll have 2 dummy questions. Asmita, can you display them, please? So the first question, in which city is Taj Mahal located? Option A, Chennai, option B, Mumbai, option C, Agra, and option D, Bangalore. The second dummy question, how many oceans are there? Option A, 8, option B, 5, option C, 6, and option D, 7. So I hope those interested to participate in the quiz have logged in their answers. So over to Shaila ma'am to share the screen and start the quiz, ma'am.
Raja, you'll have to stop screen sharing.
Yeah, the answers will be later after after the meeting is over, right?
Yes, ma'am.
Yes.
Just the questions done. Yeah, slideshow.
Just 1 second. Sorry about that.
No, that's okay.
Okay. So this is the quiz for the day. And the first question for the day is that when you look at the National Iodine Deficiency Disorders Control Program, which was one of the most successful programs in our country as far as correction of iodine deficiency disorders go, which year was this actually decided? And when we talk about iodization of salt, when you're talking about parts per million, what do you exactly mean on the table? Are you talking about salt with more? Both these questions are actually intertwined in the answer. So you will have to look at both. You will have to look at which year the decision was made and what do you mean by iodization of salt. So is it salt with more than or equal to 15 parts per million of iodine, and was this decided in 1962? Salt with more than or equal to 15 parts per million of iodine in 1982? Salt with more than or equal to 20 parts per million of iodine in 1972? Or was it salt more than or equal to 30 parts per million of iodine in 1992? So this is when, which year was the decision made, and what do you mean by iodization of salt? Ma'am, I wait for 30 seconds between the questions and then go to the next question.
No, ma'am, you can continue.
I continue.
10 seconds. Only 10 seconds, Shaila.
Okay, ma'am. Fine. The second question is consumptive hypothyroidism. What is it characterized by? It is characterized by all of this except 4 answers are high levels of D3 expression by neoplastic tissues, resulting in high rates of thyroid hormone inactivation. High doses of LT4 and or LT3 are required to normalize serum thyroid hormone levels. It is most commonly seen in solid tumors in adults, or serum TSH screening should be done in the evaluation of patients with hemangiomas. All this is right regarding consumptive hypothyroidism, except one of those answers over there. Now, when you look at the diagnosis of Hashimoto's encephalitis, there's definitely 3 criteria which should be met, except more than 3 months of memory deficits, altered mental status, or psychiatric symptoms, new focal neurological deficits, unexplained new onset seizures, CSF pleocytosis, or MRI features suggestive of AE, reasonable exclusion of other possible causes of the condition, and the last option is elevated titers of anti-TPO antibodies. So which 3 are you going to consider to be very important when you make a diagnosis of Hashimoto's encephalitis in your consultings? Are you going to be thinking in terms of more than 3 months of deficits, new neurological deficits, exclusion of other causes, and elevated titers of anti-thyroid, anti-TPO antibodies? This is a photograph which is showing black discoloration of a diffusely enlarged thyroid gland. This is the macroscopic picture and this is the microscopic picture. And what you have over here is a black thyroid. Is this with prolonged therapy with which drug? Except tetracycline antibiotics, antidepressants, lithium, or ciprofloxacin. These are the 4 options that we have over here. Where is a black thyroid actually seen? Now, when you look at this microscopic picture of the thyroid over here, what would you think about? Would you think about an amyloid goiter containing adipose infiltration? Would you think about heterotropic adipocytes? Would you think about a thyroid lipoma or adenolipoma? Or would you think about diffuse thyroid lipomatosis? What would you think about if you saw this kind of microscopic picture as far as the thyroid gland goes? We are seeing USG all the time when we are evaluating thyroid nodules. Which are the features that are consistently associated with malignancy in a thyroid nodule, except hypogenicity, infiltrative, irregular, or lobulated margins, intranodal microcalcifications, or wider than taller shape? What would you as a clinician look for when you're looking for a malignancy in a thyroid nodule? Or what is it that your sonologist would report except one of these findings? There was a big furor. There's still a little bit of controversy as to when a malignancy was downgraded to non-cancerous encapsulated follicular variant of papillary thyroid carcinoma. Now, which malignancy was this which was downgraded? Was it non-invasive follicular thyroid neoplasm with papillary-like nuclear features, or NIFTP? Was it Hürtel cell carcinoma? Was it thyroid lymphoma? Or was it papillary microcarcinoma? One of these lesions was downgraded to be called as an EFVPTC. Which was it? MCT8 deficiency, we all know, is a rare genetic leukoencephalopathy caused by a defect of thyroid hormone transport across cell membranes, associated with some movement disorders. Which is the most common movement disorder seen? Is it dystonia? Is it hypokinesia? It is paroxysmal movement disorders, or is it chorea? When you're talking about recurrent thyroiditis, is it uncommon in Riedel's thyroiditis, Hamburger thyrotoxicosis, silent thyroiditis, or thyroid amyloidosis? And the last question of the day, this is something which you already heard just now. This shows the gradual loss of thyroid reserve over time due to thyroid autoimmune diseases. And after the first episode of postpartum thyroiditis, what is the chances of recurrence after a subsequent pregnancy? Is it 70% in women who are TPO antibody positive? Is it 50% in women who are TPO antibody positive? Is it 25% in women who are antibody positive, or is it 40%? What is the chance of recurrence? This is the last question of the quiz, and we'll get back to the answers after both the presentations. Thank you very much.
Thank you, Madam.
Thank you, ma'am. In fact, it has been a very interesting quiz. I think we will have to go back to the books to look for answers. Very, very interesting quiz, ma'am.
Thanks. I back to the books also.
Thank you, ma'am. So now moving on to the most awaited session, that is the session on thyroid and both. I would like to request Dr. Naresh sir to introduce Dr. Amrish Mittal sir, who is the esteemed speaker for the next session. Over to you.
For the next session, we have Padma Bhushan, Dr. Amrish Mittal. In endocrinology, I think there won't be anybody who don't know sir. He's the chairman and the head of endocrinology, Max Hospital. He's a domain expert on the governing board of the National Health Authority of India and the president of AIIMS Gorakhpur. In 2021, he has been presented the Laureate Award from the Endocrine Society of USA for International Excellence. And he's a recipient of the Fogarty Fellowship from Harvard Medical School, Japan International Cooperation Agency Fellowship, Boyframe Award of American Society of Bone and Mineral Research, and a Springer Citation Prize for his paper on global vitamin D status. He has been conferred the Indian Osteoporosis Federation President's Award, World India Diabetes Foundation Outstanding Achievement Award, and Fellowship of ASBMR. We are privileged to have you, sir, here. Over to you, sir.
Thank you very much. And it's a pleasure to be here. And thanks to Dr. Bajaj for involving me and inviting me. The topic she has assigned to me is about thyroid and bone. And it's an area which is often talked about quite loosely without people actually trying to understand. I'm sure it's not true of this group, but very often physicians talk very loosely of thyroid and bone. You know, thyroid medicine will damage the bone and all this kind of things. So I think we need to put it in some perspective, and I will try in my own small way to try and explain the relationship between thyroid and bone. Yeah, is it visible?
Yes, all good. But yeah, perfect.
So we'll be talking about thyroid and bone and the relationship today. And of course, we all know the relationship exists because we all know that children, how were you taught to diagnose hypothyroidism as a cause of short stature in children? The first thing you looked at was the bone age. So the association between thyroid and bone is very, very clear and it's there for a long time. But today we'll go a little deeper into that. After introducing the subject, I'll talk a little bit about mechanism. I've tried hard to simplify that, not to make it complex or boring. Then the role of thyroid hormone in skeletal development, role of thyroid hormone in adult bone. So first development, then adult bone. In the adult bone, impact on bone remodeling, overall fracture rates, etc. What happens when you combine with D deficiency, which is so common in Indians, and then a little bit about hypothyroidism and the skeletal system. And I'll try and conclude. So over a century ago, a young woman who died from thyrotoxicosis, imagine, was noticed to have bones that looked worm-eaten. The first systematic study of clinical effects of thyrotoxicosis on the skeleton was actually as late as 1972. And it was 187 patients with thyrotoxicosis, out of which 8%, that is 15, had skeletal symptoms. And out of these 80%, those who had skeletal system were mostly older, more than 50 years old, and 2/3 of those had a fracture or severe bone pain. However, now seeing patients of thyroid dysfunction with overt skeletal manifestation in adults are much less common. I mean, it's very rare for me to see someone where I can ascribe the bone problem largely to the thyroid problem. I'm not talking of children who come with growth retardation, but in adults, it's very unusual to find somebody whose bone problem can be totally or predominantly ascribed to the thyroid. So thyroid hormones do play an important role in calcium homeostasis. Thyroid hormone receptors, alpha and beta, alpha 1 and beta 1, beta 2 are universally expressed. They play a key role in skeletal development, acquisition of peak bone mass, and regulation of adult bone turnover, right? Development, whether the peak bone mass is achieved or not, and regulation of bone turnover in adults. Thyroid hormones exert anabolic, and now this is an oversimplification, but I tried to make it sort of something, a catch line that we'll remember in the clinical setting. Thyroid hormones exert anabolic actions during growth, but catabolic action after fusion of epiphysis. I hope that makes some sense, that if during growth, if you have thyroid hormone excess, you get faster bone growth and you get maybe earlier fusion, you get more sort of advanced bone age. Overall bone density might, I mean, the bone growth might increase. But once the epiphyses have fused, then the action becomes catabolic. And again, I'll explain that because that action through the chondrocytes is an anabolic action. An action direct on the bone is a catabolic action, and we'll go over that. But yes, in the overall adult endocrinology setting, hyperthyroidism or either iatrogenic or endogenous, may play a role in the development of osteoporosis. So as usual, as I said, it is not typically the only risk factor. There are other risk factors, and thyroid also adds to that. So what is the mechanism of action of thyroid on the bone? We all know that thyroid hormone acts through thyroid receptors. Thyroid receptors are intranuclear, and often there is a whole family of thyroid hormone, retinoid acid, and other receptors, which is important. But here, what we are seeing is that if you look at the T4 entering the cell or T3 directly entering the cell, deiodination, some of them go by, they are deiodinated by deiodinase 3, and therefore they go to T2 or reverse T3, but a lot of them will become T3, and T3 will come in directly. So first they come in through these transporters, MCT8, MCT10, and OATP1C1 through the transporters on the cellular surface, then reach inside the nucleus after this deiodination, etc. And this T3, which is predominantly the active form of the hormone, and as we always say, there is some T3 that comes in directly through circulation, but a lot of it is formed in the cell itself. This then binds to the thyroid hormone receptor, and the thyroid hormone receptor is then combined with the retinoic acid receptor, and both combine to the thyroid response element, which then leads to transcription and translation. So this is the typical action, as oversimplified action of thyroid hormone. However, what happens in this is, what happens in the bone? Basically, both TR-alpha-1 and TR-beta-1 receptors are expressed in the bone, but the predominant one, tenfold higher, is TR-alpha-1. So the TR-alpha-1, let's look at this here. Let's look at the bottom part first. So T4, T3, and everything gets converted to T3, right, before its action. They actually bind to the TR-alpha-1 receptor, the same thing that I showed, to produce effects. But then the reason this slide is being shown is also that there is a role of TSH. There are TSH receptors in the bone cells. And I think that's important to understand, that TSH plays an important role in bone remodeling, independent of T4, T3. In fact, my friend Mone Zaidi, whom Sarita knows, actually calls TSH the bone suppressing hormone. So it is important to understand that there is TSH receptor on the bone, and the TSH has direct actions. Slightly complex slide, but nevertheless, we all know what is the osteocyte. Osteocyte is a cell embedded in the bone, which sends the first signal for the remodeling cycle. So no action, effect unknown, forget osteocyte. Let's look at the chondrocyte, which is very important. If you look at the chondrocyte, the bottom half of this cartoon is all about T3 action, and the top half is about TSH action, showing that the action of the skeleton is a joint effect, a combined effect of T3 and TSH. So if you look at this T3, at the chondrocyte in T3, you find that the T3 inhibits proliferation and stimulates differentiation. So it inhibits the further proliferation of chondrocyte and stimulates it to differentiate into more advanced cells, which will lead to ossification of the bone, right? So instead of unbridled proliferation, T3 will direct you towards bone formation in a way, right? Now, what happens with TSH? It probably inhibits the process, but again, it's a bit of a question mark as the exact action of TSH on the chondrocyte. This is very important, in particular for children, for growing children. What about osteoblasts? Let's look at T3 again. Stimulates differentiation and bone formation. So again, T3 via the chondrocyte and via the osteoblast is stimulating bone formation both ways. The TSH actually does funny things. Some studies, there are lots of studies. Some studies show inhibition, some show stimulation, and it goes on like that. However, when we look at the osteoclast, that I think is quite important, because in osteoclast, the action of T3 is probably indirect, and the main action is TSH, which inhibits osteoclastic proliferation. So therefore, what you are saying is that TSH actually is an inhibitor of osteoclastic activity, and a low TSH will promote more osteoclastic activity, which means more bone resorption. So T3 action on the chondrocyte and on the osteoblast, perhaps indirect on the osteoclast, TSH action on the osteoclast. So different cells are controlled by different thyroid hormones or pituitary hormones. So here we see this is the interaction between T3 and TSH. This is important to understand because that's how the field is developing. So what is the role of thyroid hormone in skeletal development? And of course, the important part here, again, I won't bore you with more pathophysiology, but the important thing is that T3 acts everywhere, increases clonal expansion, inhibits cell proliferation, stimulates cell differentiation, increases matrix production, promotes matrix degradation, stimulates bone formation and remodeling. This whole action on the growth plate is very important for what we call skeletal maturity of children. So therefore, when you have a lack of thyroid hormone, you have delayed skeletal development, even growth arrest, and of course, impaired bone maturation. With T4 replacement, there is rapid catch-up growth, and the final height is often achieved and is unrelated to the duration of untreated hypothyroidism. Often a catch-up growth is possible. Now this girl, one second. I wonder why this is. Give me 1 second. Okay.
Okay.
This sound is very irritating. Can't seem to fix it. Okay. So this is a 12-year-old girl presented with short stature to my colleague, Dr. Ganesh Devlikar, who does pediatric endocrinology in the group. And the bone age was 6.5 years. Right? So I think this is a typical example of impaired skeletal maturation because of congenital or early acquired hypothyroidism. What about thyrotoxic children? Thyrotoxicosis in children advances bone age and accelerates skeletal development exactly as you would expect, resulting in early cessation of growth. So it's like a little bit like precocious puberty, rapid growth, quickly fusing, right? And in severe cases, and described in literature, are cases of craniosynostosis, where thyroxine stimulation advanced skeletal development so much, accelerated it so much that the cranial bones got fused at an early stage. So, but the developing skeleton is exquisitely sensitive to systemic thyroid status, both hypo and hyperthyroidism. So if you look at the consequences in children and hypothyroidism, you know this very well. Delayed bone age, growth arrest, short stature, delayed closure of fontanelle. And in hyperthyroidism, there's advanced bone age, accelerated growth, premature fusion, and even craniosynostosis. What about role of thyroid hormone in adult bone? I'll spend a second here to explain what is remodeling. We have to understand that skeleton is not a dead tissue. It's constantly undergoing remodeling. These are the osteoclasts, which are multinucleated giant cells that chew up the bone here. Destruction always starts earlier and also takes a much shorter time. So these cells in one typical remodeling cycle, in a period of 7 to 10 days, will chew up bone. So once they get triggered, that's the amount of time they take, right? That's the osteoclast. And then there is, of course, communication between osteoclast and osteoblast, and bone formation occurs. Now, one good way to remember this is that this takes 7 to 10 days. This takes maybe 10 weeks, bone formation. So destruction is always easier than formation. You destroy in days and you rebuild in weeks. This is important to understand. And that's why when when we have issues with accelerated destruction, it's very difficult for formation to keep pace with that. So why am I telling you this? The remodeling process is influenced by thyroid hormones. Thyroid hormone already shown directly stimulates osteoblast. Osteoclast activity is impact of thyroid hormone is only in the presence of osteoblast. So again, to remember, bone formation is directly impacted by thyroid hormone. Bone resorption is indirectly impacted by thyroid hormone. What happens when there's hypothyroidism? If everything becomes slow in hypothyroidism, duration of remodeling cycle is increased, duration of osteoclastic resorption phase is extended twofold. So it goes on resolving, but slowly. Time for osteoblastic formation is fourfold, right? So this results in low bone turnover, and it might actually result in overall gain in bone mass and mineralization because the whole thing is slowed down so much. The duration of the resorption phase is reduced by 60% in hyperthyroidism. In hypothyroidism, everything is slow. In hyper, everything is fast, as we expect. Duration of resorption phase, formation phase, but bone resorption is increased to a greater extent than bone formation. In hypothyroidism, bone formation is increased to a greater extent than bone resorption. Bone resorption is reduced to a lesser extent than bone formation in hypothyroidism. Yeah, I'll explain this again, right? So you have impact on both resorption and formation, but the impact is more so that in hypothyroidism, there is more dense bone, there is more bone formation, right? Because the impact is more on osteoblast than on osteoclast. In hyperthyroidism, the impact is more on the resorption phase, the impact is more on the osteoclast. So bone resorption is increased to a greater extent. Net result is in every cycle, every remodeling cycle, there is 10% of bone is lost in every remodeling if one has untreated hyperthyroidism. And obviously, you will have increased bone resorption. That's why you sometimes get hypercalcemia. If you do bone turnover marker, they are high. When people were left untreated, even 20% of them had mild hypercalcemia. What happens? Does it lead to fractures? Thyrotoxicosis is associated with increased risk of hip and spine fractures and is an important cause of secondary osteoporosis. In meta-analysis by Westergaard, they found that bone densities were lower, but after treatment, recovery is very good also, after treatment of thyrotoxicosis. So while the bone density recovers, it does seem that a past history of thyrotoxicosis is still a risk factor for hip fractures later in life. You understand the difference? Bone density, you treat hyperthyroidism, recovers very well. But when you analyze patients with hip fracture, one of the minor risk factors is a past history of hyperthyroidism. In other case control studies, the odds ratio was 2.5 in postmenopausal women. Risk factors for hip fracture in women more than 65. So thyrotoxicosis was among the risk factors. It's not a powerful risk factor, but a history of thyrotoxicosis. Of course, uncontrolled, untreated thyrotoxicosis is an important risk factor, but even a history makes a difference. So this one looked at those who had past history. And even there, the risk was somewhat doubled. And hip fractures were not increased in this study, Danish study, but spine and forearm. I think it's enough for us to remember that if people are thyrotoxic and untreated, their risk for fractures is high, maybe more than double. But even in those who get fractures, a history of past thyrotoxicosis, even treated, is not uncommon and is a minor risk factor. What about exogenous thyroid hormone? The most important question for everybody, what about when we use thyroxine? All that impact has been seen in postmenopausal women. So that's very important. Very little data shows any impact on younger women or men. And you can see throughout the talk is only about women. There's very little data on men. The study of osteoporotic fractures in the US, that if you had a baseline serum TSH less than 0.1, and if you keep it that low, yes, you will increase your risk of hip and vertebral fracture, right? Look at the differences. 1.6% in the UK general practice database, 1.4% controls. So it's a minor difference, but it's there. Subclinical hyperthyroidism, we don't really know unless the TSH is really low. So I think it's important to make sure that the TSH is normal, and treating it will improve the bone density. We can leave this. In summary, supraphysiologic doses of T4 may decrease bone density and increase fracture risk, but the effects are small and most likely to occur only in postmenopausal women and those with TSH concentrations well below the 0.4 or whatever normal range you're using, or 0.5. I think that's important, right? What about just one line about Dinesh Hanwal's work on patients who have vitamin D deficiency and thyrotoxicosis? You will find much more impact pathophysiologically and otherwise, because if you have a low vitamin D, have a high PTH, you get more turnover, more bone loss, and the whole thing just amplifies. What about hypothyroidism in adults? Low bone turnover, as I showed you, greater impact on formation, so that formation is slow and steady, and resorption is also slow, but formation is not as slow as resorption. So you get a net balance in favor of formation in hypothyroidism. So you probably have little increase in bone mass, but this also reverses when you treat them with thyroxine. But the interesting part is that even with normal bone density, it is possible that these patients may be at higher risk of fractures. Several studies have shown that it's not like absolutely level 1 evidence, but yes, there is some evidence that patients with hypothyroidism in the first few years of their hypothyroid status, and it is thought that it may be because thyroxine is initiated at that time, that there may be an increased risk of fractures, which goes away with time. Subclinical hypothyroidism, available data do not demonstrate anything, so forget that. So summary, hypothyroidism, T4, T3 low, TSH high, skeletal consequence, reduced bone remodeling, but in favor of bone formation. Articular changes, osteosclerosis, but some increase in fracture risk. Hyperthyroidism, clearly bone resorption more than formation, low bone density, osteoporosis, fractures, and as I said, both ways, definitely in active thyrotoxicosis in postmenopausal women, but also in those who've had a past history. Of course, we won't talk about bone metastasis here. To conclude, if you look at endocrine regulation of bone by thyroid, this is hyperthyroidism on the left. Hyperthyroidism on the left. Okay? In hyperthyroidism, the amount of bone resorption is greater than bone formation, a point I have said many times, but it's good to take home this message, right? And therefore, in adults, there will be bone loss. In children, there will be craniosynostosis, and there will be advanced bone development. So think of just precocious puberty, and the same thing will happen here. On the right side is hypothyroidism. So there is lack of thyroid hormone. There, both bone formation and resorption are reduced, but resorption is reduced more than formation. So there is accumulation of bone. And in children, there is delayed closure of fontanelles, persistently patent skull sutures, and delayed bone development. So either way, you'll end up with a dwarf. Okay, in untreated hyper and hypothyroidism. Either way, you'll end up with a greater risk of fractures. More pronounced, greater risk of fractures in hyperthyroidism, less so in hypo. Here, greater dwarfism in hypothyroidism in children, lesser in hyper, but still it's possible. And if you have really untreated hyperthyroidism, which then you can have very severe dwarfism even in hyperthyroidism. So timely diagnosis of thyroid dysfunction, appropriate treatment and regular follow-up, aim for cure in cases with hyperthyroidism, don't let them fluctuate hyperthyroid all the time, correction of modifiable factors, ensuring calcium, vitamin D, at least to make sure they don't add to our trouble with bone and thyroid. Thank you very much. A recent sunset I captured, I think 2 or 3 days ago during one of my evening walks. Thank you.
Thank you.
Thank you. Topics easy. I think everybody should be able to understand now the effect of thyroid hormones on the bone. Thank you so much, sir. So there's one question which has come up in the chat box.
Yes.
Is routine calcium supplementation required while giving thyroid hormone replacement therapy?
I think it's a good question. It depends on 2 things. It depends on the patient's calcium intake baseline. If someone is really deficient in calcium, which some of our patients don't take any milk products, anything at all, they're either lactose intolerant, don't like the taste. So poor calcium intake, yes, you should replace. And this is particularly true if the person is at high risk for osteoporosis. And in this case, all the data is on postmenopausal women. So yes, if you put a postmenopausal woman on thyroxine, it's a good idea to add some calcium vitamin D. It may not be true for everybody across the board. In others, if you can see visibly or on asking a poor calcium intake, then you may want to add that.
So there's a small question I wanted to ask. Since thyroid, both hypo and hyperthyroidism is known to cause osteoporosis and affect the bone, should thyroid disorders also be included in the fracture risk course?
Yes. So why are they not in the fracture risk score? Because they are not major risk factors. So they're minor. There are lots of minor risk factors which are not included there. No? Only the ones that really have an impact. So, but when you evaluate a patient, when you're deciding treatment, deciding risk, then it's good to know the thyroid status. But it's not strong enough to become a major risk factor at the moment.
Sir, thank you, sir.
Yes, I think.
Sarita, ma'am.
Yeah, lovely. Wonderful talk, Amrish. Thank you so much for joining us. It's an honor to have you. The question was like, so routinely we would not do a BMD just for the sake of hyper or hypo. Of course, we would keep all the other important risk factors in mind. So like you said, if it's a post-menopausal, obviously, if it's a woman and she has associated thyroid problem, but we would not do it from the focus. And these days, I think we do pick up cases relatively early, isn't it? So
yes,
both hyper and hypo, we are able to diagnose them in good time.
Yes, much
like what you said, when you said when it was the bones were totally eaten away, the first case when you said way back, isn't it? So is there any marker which can tell us, this particular patient really does need to be investigated? Because it's like you said, it's a very
so I think, Sarita, the indications for bone density measurement wouldn't really change that much. I wouldn't do it in younger patients at all. There is no such recommendation. In older patients, it's a soft sign. So, for example, if you're sending all your women over 60 and men over 65 for bone density, maybe you will send them a little earlier, women at 58, 55, 52. You may want to consider postmenopausal women with thyroid condition. You may want to consider bone density earlier. I think that will be the only change. Same as we do with diabetes now, that with people with diabetes, we tend to screen earlier. So something like that. But there is no written recommendation about this. There is no indication for screening younger patients. In postmenopausal women and older women, you may ask for a bone density a little earlier than you would otherwise. I think that's how I would leave it.
And that too for the overt hypo and hyper. I mean, it's like subclinical,
Subclinical,
you said there's no evidence.
I would not.
Isn't it?
Yeah, there's no data on subclinical to really show that much.
Thank you. Thank you so much.
Thank you, sir. Thank you, sir.
So, Naresh, do you think
should we move on to the quick answers?
Do you think Vikram would be able to join us for the question answers, or will be?
Yes, ma'am. Vikram is ready to join us, ma'am.
No, but is he able to share screen now, or still having a problem? So I thought then we'll just do the Q&A. There are a lot of questions in the chat box. So if you can join us, or at least Amit is there and you are there. Of course, Amrish is
Hello.
always there. Pramila,
Madam,
Hello.
Dr. Vikram here, since I'm traveling, a few issues are really out of my control. So we've been trying to fix up the internet here, but probably whenever I'm sharing my video, I'm not able to share my slide. But I believe my voice is...
yeah, good.
Sir,
We can hear
I
you
have
very
your,
well. So can we do
Sir-
the Q&A? Yeah,
And
sorry.
I've sent my presentation to...
sir, I shared your slides.
No, I don't think
And
that
this-
helps. I don't think that helps. Okay, you want to share the slides and you'll be talking. Can you, okay, let's see that.
So should we go ahead and discuss this, madam?
Yeah, I can go through them. Okay.
Thank you, madam, for giving me an opportunity to speak today. I really apologize for the technical glitches earlier. The topic that I have been given for presentation today is hyperthyroidism in pregnancy. And next slide, please. I'll be covering the topic under the following heads. Next, please. We'll be discussing today's topic in the background of this case, a common presentation that we commonly encounter in our clinic. A 30-year-old female who presented in the 12th week of gestation with history of generalized weakness, lethargy, palpitation, vomiting about 10 to 12 episodes per day for the last 2 days. She had history of hyperemesis gravidarum in her first pregnancy, and there was no history of any chronic illness or thyroid disease in family. On presentation, she had tachycardia, her BP was on the lower side, she was dehydrated, had mild icterus. However, there was no thyroid enlargement or orbitopathy. Her LFT was mildly deranged. She had potassium was on the lower side. Her free T4 was slightly raised and TSH was suppressed. Next slide, please. The diagnosis and management, I'll come back later after the presentation. And thyroid disorders, as we know, are the second most common endocrine disorders affecting women in the reproductive period. And women are likely to experience thyroid-related problems during pregnancy, as pregnancy is known to have profound impacts on the thyroid gland and its function. Hyperthyroidism is not as common as hypothyroidism in pregnancy, but it still occurs in about 0.6%. Overt hyperthyroidism occurs in about 0.6% of pregnant females, and another 1.8% pregnant females can have subclinical hyperthyroidism. Recognition and proper management of hyperthyroidism during pregnancy is of utmost importance, as we all know that overt hyperthyroidism has severe adverse impact on the health of severe health impact on the maternal and fetal well-being. Given the complexity surrounding the thyroid physiology and thyroid illness during pregnancy, how and if to treat thyroid illness during pregnancy remains a challenge. Next slide, please. I'll be briefly covering the physiological changes in the thyroid function test during pregnancy. Next slide. The thyroid hormones circulate in plasma, non-covalently bound to 3 transport proteins: the thyroid binding globulin, albumin, and transthyretin. And despite the fact that TBG in serum is by far the least abundant of these 3 transport proteins, about 2/3 of the T4 in serum in normal subjects is carried by thyroid binding globulin. This is largely because of its extremely high affinity for the hormones. In conditions with TBG excess such as pregnancy, the proportion of circulating T4 being carried by TBG is even greater, increasing up to 75%, which indicates that TBG represents a major thyroid hormone binding protein in pregnancy. The bound hormone fraction is in equilibrium with the free unbound fraction, which, though smaller in amount, represents the active fraction of thyroid hormone. Next slide. In pregnant women, the serum TBG rises sharply few weeks after the beginning of pregnancy and reaches a plateau around mid-gestation. It rises up to around 2.5-fold higher than the initial value. Subsequently, the TBG concentration remains stable until term. This rise in TBG is due to estrogen which drives increased hepatic synthesis of TBG and also results in increased chelation of TBG, leading to its reduced hepatic clearance. And parallel to this rise in TBG, the total T3 and T4 also rise in parallel to TBG. Next slide. An important consideration during pregnancy is also the relationship between serum TSH and HCG. HCG is a glycoprotein which is produced by placenta and corpus luteum. It has a weak agonist activity at the TSH receptor, and the levels rise rapidly in early pregnancy and reach a peak at around 10 to 12 weeks of gestation. The HCG, by stimulating the TSH receptors, results in increased thyroid hormone synthesis, and which suppresses the TSH production. As you can see, the both HCG and TSH levels in pregnancy are the mirror images of each other. While HCG rises sharply at around and peaks at around 10 to 12 weeks, the TSH reaches a nadir at around the same time.
Dr. Vikram, we are not able to hear you.
Sir, am I not audible?
He is audible.
He is audible. We can hear, actually.
So my internet connection is a little...
No, we can hear. You can go ahead. We are able to hear.
Go ahead. Please go ahead. Please go ahead.
In certain conditions which are associated with high HCG levels like hyperemesis gravidarum and H-mole, the reduction in TSH may be more marked. Next slide, please. A few words about the iodine physiology during pregnancy. As you know, the dietary iodine requirements are higher in pregnancy, while the normal requirement in a non-pregnant female is around 150 microgram per day. The WHO recommends this to be increased to 250 microgram per day in pregnancy. This is largely because of because in a pregnant state, the women requires excess iodine for increased thyroid hormone production. There is also an increased maternal and renal iodine clearance. The placental T3 deiodinase deactivates T4, and there is also a certain amount of thyroid hormone which passes on to the fetus across the fetoplacental unit. And in iodine deficient regions, this may result in an increase in maternal TSH levels, and the thyroid size may also increase. The thyroid size in iodine deficiency regions might increase up to 30 to 40%. This is in a nutshell what happens in altered thyroid physiology during pregnancy. The TBG level rises, the T4 level rises in parallel with it. The HCG and TSH levels are mirror images of each other. The free T4 might rise transiently during the first trimester and then gradually tapers off to a level which is at or a little less than pre-pregnant stage. Next slide, please. So then what is normal during pregnancy? The guidelines recommend that population-based trimester-specific reference range should be used for TSH values in pregnancy. However, if they are not available in first trimester after first 6 weeks, the lower reference range can be reduced. Lower reference range is reduced by 0.4 and the upper reference range is reduced by 0.5 to derive the normal TSH values in first trimester. In second and third trimester, the TSH values gradually return to the non-pregnant range. With regards to total T3 and T4 for the first 7 weeks, they are much the same as in non-pregnant ranges. And after from 7 to 16 weeks, there is a rise by, you can increase the upper limit of normal by 5% per week. And beyond 16 weeks, the normal range is upper limit of normal multiplied by 1.5. This is what constitute the normal T3, T4 and TSH ranges in pregnancy. A few words about the thyroid-related substance and their crossing of placental barrier. While the maternal TSH does not cross the placenta, the thyroid hormones, the TSH receptor antibodies, the anti-thyroid drugs, and certain amount of beta blockers. Next slide, please. Coming on to the causes of thyrotoxicosis in pregnancies, the spectrum of diseases causing thyrotoxicosis in pregnancy is much the same as in non-pregnant stage. Graves' disease and Gestational transient thyrotoxicosis are the most common causes. Thyrotoxicosis in pregnancy can also be caused by overtreatment of hypothyroidism. Some rare causes include toxic multinodular goiter, toxic adenoma, subacute thyroiditis, TSH secreting adenomas, and functional thyroid metastasis. While the causes in the lower half are very rare, overtreatment of hypothyroidism can easily be made out during the from. So you are essentially left to differentiate between Graves' disease and gestational transient thyrotoxicosis in patients who present with thyrotoxicosis in pregnancy. It is important to distinguish between these two entities as disease course and treatment are different. Next slide, please. Gestational transient thyrotoxicosis is a transient hyperthyroxemia mediated by high levels of HCG. It occurs in about 1 to 3% of pregnancies, and it is associated with hyperemesis gravidarum, multiple gestation, H-mole, and choriocarcinoma. Patients rarely have severe thyrotoxic symptoms and usually lack the typical signs of Graves' disease like thyroid enlargement and orbitopathy. The TRAB antibodies are negative, and the condition resolves spontaneously as HCG levels decrease about beyond 10 to 12 weeks of gestation. Next slide. The treatment of this condition is largely symptomatic. Control of vomiting with antiemetics, correction of electrolyte disturbance, and treatment of dehydration with IV fluids. Antithyroid drugs are not indicated for the fear of their teratogenic effects, and also because the condition is transient and resolves spontaneously beyond 16 weeks. The beta blockers can be considered in situations where symptomatic therapy is indicated. When used, they are to be used in the least possible dose and for minimum duration. And of course, importantly, the thyroid function test should be followed periodically through resolution of abnormalities so that you don't miss out on rare causes. Graves' disease is a common cause of autoimmune hyperthyroidism, both in non-pregnant and in pregnant states. It may both pre-exist and may also occur during pregnancy. The incidence is high in the first 3 months, lower in the last 3 months, and the incidence is maximum about 8 to 9 months postpartum. From a diagnostic point of view, women with history of Graves' disease who already are a known case of Graves' disease pose no problems. In contrast, diagnosis of Graves' disease first occurring during pregnancy may be difficult because many clinical symptoms of hyperthyroidism, such as palpitation, sleeplessness, anxiety, fatigue, are non-specific and may be overlooked or interpreted as normal pregnancy symptoms. And there is considerable overlap between symptoms of gestational thyrotoxicosis and mild Graves' disease. However, goiter, orbitopathy, and TRAB antibodies are positive in patients of Graves' disease, and the treatment is the mainstay of treatment. Next slide, please. The effect of pregnancy on Graves' disease. It is important to go through this slide so that we know how to treat them. The symptoms of Graves' disease are aggravated during the first trimester, largely because of increased HCG production. The thyrotoxicosis symptoms improve during the second and third trimester of pregnancy. This is largely due to reduction of TSH receptor stimulating antibody, and the symptoms recur and even exaggerate about 8 to 9 months postpartum. This is largely due to increase in the TSH receptor antibodies, largely due to fall in Treg cells. Next slide. So an important slide, how do we differentiate gestational transient thyrotoxicosis from Graves' disease in pregnancy? Well, family history of thyroid disease or prior history of thyroid disease goes in favor of Graves' disease. The clinical signs of symptoms are usually absent or maybe mild in gestational thyrotoxicosis. However, in Graves, the symptoms may range from mild to severe. The presence of goiter, orbitopathy, dermopathy, and TRAB antibodies virtually seals the diagnosis of Graves' disease. and the presence of hyperemesis, multiple pregnancy usually favors gestational transient thyrotoxicosis. While the course of GTT is self-limiting, the Graves' disease has an unpredictable course during pregnancy. The serum HCG levels are higher in gestational transient thyrotoxicosis as compared to Graves' disease, but the overlap is considerable and the clinical usefulness of this is limited. With regards to the value of ultrasound, thyroid ultrasound for differentiating between these two conditions, the guidelines recommend that there is considerable overlap here also, and no study has demonstrated usefulness of thyroid ultrasound for differentiating between these two conditions. A thyroid scan is of course contraindicated in pregnancy. Next slide. So why are we worried about hyperthyroidism in pregnancy is because it has a serious implication for both maternal and fetal health. Uncontrolled hyperthyroidism can cause congestive heart failure and thyroid storm in pregnant females, and it can also cause preeclampsia, premature delivery, placental abruption, and premature rupture of membranes. The fetus can develop congenital malformation largely due to the use of antithyroid drugs. The fetus might also develop both hyperthyroidism, hypothyroidism, goiter. Developmental dysplasia of hip has been reported in fetus with uncontrolled hyperthyroidism, particularly in first trimester, and they can also develop intrauterine growth restriction, and they can be born small for gestational age. Next slide.
Sir, can I interrupt you for 1 second? Are there any complications of subclinical hyperthyroidism as compared to overt hyperthyroidism?
Well, the complications of uncontrolled hyperthyroidism I've already brought out, but subclinical hyperthyroidism has shown that it doesn't affect either the maternal or fetal outcomes. So I hope have answered your question clearly.
Yes.
The complications associated with subclinical hyperthyroidism are not significant. So what if a lady with Graves' disease who is on treatment, what advice how you are going to counsel these patients who are who already have Graves' disease? In all women of childbearing age who are thyrotoxicosis, the possibility of future pregnancy should be discussed with them. The pregnancy should be postponed until a stable euthyroid state is reached, and you should strongly recommend contraception until the disease is controlled. And hyperthyroid patient who desires future pregnancy, you should discuss the potential risk and benefit of various therapeutic options, and you should inform them about the need for regular medical visit and serial thyroid function test during pregnancy, explaining them the risk of uncontrolled hyperthyroidism. Next slide, please.
How much more is there to go? Okay, we're coming to the treatment part.
Treatment, ma'am. Anti-thyroid drugs are the treatment of choice.
Okay.
Thyroidectomy are to be considered in specific situations.
Excuse me, how many slides more to go?
Madam, I think another 5-6 slides.
Okay, can you wind up, because
Yes.
we should finish by...
Next slide, please.
Yeah.
Antithyroid drugs, as I told, are the mainstay of treatment. The choice depends on the trimester. Propylthiouracil is preferred in the first trimester, while methimazole is preferred in the second and third trimester. The side effects happens in about 3 to 5% of the patient. Next slide. Next slide. The main concern with the propylthiouracil is hepatic necrosis causing acute liver failure, for which it is largely avoided. And next slide. Can you hear me, ma'am? Am I audible?
Yes, you are audible.
The greatest risk surrounding the use of antithyroid drugs in pregnancy is related to their potential teratogenic effects.
I think this is okay. I think this is a very clear slide. Can we move on, please?
So the teratogenic effects happen in about 2 to 4% of children. Previously, the propyl thiouracil was considered safe. However, recent studies have shown that the incidence of teratogenic effects are much the same. However, are equal in incidence with regards to methimazole. However, these are less severe. And it is propyl thiouracil is usually associated with face and neck cysts and urinary tract abnormalities in males. So essentially, the point to be remembered is the incidence is much the same. However, the defects are less severe in propyl thiouracil. Next slide. The principles of antithyroid drug administration. Well, the target should be. Well, you should remember that the fetus is more sensitive to the antithyroid drugs. So when mother is made euthyroid, the fetus is often overtreated. So both overtreatment and poor control of hyperthyroidism should be avoided. And you should target maintaining the maternal free type T4 at or just above the upper limit of normal, or total T4 about 1.5 times the upper limit of normal. Next slide. This is essentially what I've spoken already. If the maternal free T4 are greater than normal, the percentage of neonates with hypothyroidism is close to 0. Well, if the maternal free T4 is less than normal, almost all neonates develop hypothyroidism. So the target should be free T4 at the higher limit of the upper limit of normal. Next slide. So can you withdraw, given the concern of the teratogenic effects of antithyroid drugs, can we withdraw antithyroid drugs in early pregnancy? Well, a certain subset of females who are requiring low dose antithyroid drugs to maintain euthyroidism, where the serum TRAb levels are low or undetectable, where the TSH levels are normal, and in females who have already received therapy for longer than 6 months, and where the ophthalmopathy is not there. In these subsets of patients, you can consider stopping the antithyroid drugs in pregnancy. But if you are going to stop the medication, you should remember that the period of greater concern should be gestational week between 6 to 10. This is the period when greatest teratogenic effects happen with the antithyroid drugs. And if you wish to withdraw these antithyroid drugs, you should do it during this time. And of course, stopping these antithyroid drugs, you should monitor them with thyroid function tests and clinical examination routinely. And subsequent decisions should be based on the clinical and biochemical assessment of these patients. Next slide.
Dr. Vikram, can we wind up quickly?
Okay, so beta blockers have to be used, are used for symptomatic therapy for HCG-induced thyrotoxicosis or bridge when starting thyramides. You should remember is that atenolol is contraindicated because of risk of fetal hypoglycemia, bradycardia, and IGR. Beta blockers, however, unlike antithyroid drugs, are not teratogenic. Next slide. Indication of thyroidectomy is
we can move on, please. Yeah.
Next slide. So coming back to the case that we had, her TSH receptor antibodies came out to be negative. The viral markers were negative. She was diagnosed to have hyperemesis gravidarum with gestational transient thyrotoxicosis, and we treated her with IV fluid with potassium replacement, and her thyroid function test normalized after 4 weeks. Next slide.
No, we can't hear you any longer.
We are not able to hear you, Dr. Vikram.
I think we can now go to Shaila and have the answers to the quiz. I think this is the last summary slide.
Yes,
Shaila?
ma'am.
Yes, ma'am.
Dr. Vikram, we'll go on to the quiz. We'll go on to Shaila, madam, and
yeah, we'll have the
give
quiz
us the
answers,
answers.
and then we'll do some questions, and then we'll call it a day. Thank you, Shaila.
Most welcome, ma'am.
Yeah.
I'm
This
just
question 9, we've jumped straight to question 9.
sorry, ma'am.
I think the computers sometimes have a mind of their own.
I'm just trying to sort that out. I don't know why this is happening. Just 1 minute. Yeah, ma'am. That's it. Okay, sorry about that. Okay, so coming to, I still can't figure out why this is happening, ma'am.
I think we can do it
Okay,
without
I'll do this
the,
way.
without the slideshow. We can continue.
I could do it, ma'am. Thank you.
Yeah,
Thank
in
you.
case there's a problem. Yeah.
Ma'am, yeah. Ma'am, the first question, answer to the first question which we spoke about, which was a National Iodine Deficiency Disorders Control Program. They made a decision to iodize salt when in 1982, and their decision was based on the fact that they decided that they would iodize the entire country in 10 years, that is by 1992. And at this point of time, what is accepted as the iodinization of salt is at least 15 millimeters of 15 parts per million of iodine in salt at the household level. At least that is mandatory when you're talking about iodization of salt in our country. Question 2, which was again a very, very interesting question, because it is consumptive hypothyroidism is characterized by all except it is seen most, the wrong, and the answer is most commonly seen in solid tumors in adults, because as we all know, consumptive hypothyroidism is actually a hypothyroidism which is characterized by high levels of D3 expression by neoplastic tissues, and this results in high rates of thyroid hormone inactivation. This is seen more in vascular tumors. It is seen it is not seen actually in solid tumors at all. It is seen a lot in hepatic hemangioma, especially in the pediatric age group. And that's the reason why it has become mandatory that serum TSH should be screened whenever you are evaluating any patient with consumptive hypothyroidism, especially in a patient with hemangioma, because that is considered to be one of the factors that could be contributing in a very big way when you're looking at such patients. The third answer which we had was the question on the diagnosis of Hashimoto's encephalitis. What I would like to put across over here, the answer is more than 3 months of memory deficits, altered mental status, or psychiatric symptoms is the wrong answer over here. And the reason I'm saying it's the wrong answer is, when I'm talking about wrong answer, I mean it is what does not fit in the diagnosis of Hashimoto's encephalitis. That is because this is supposed to be an acute or subacute encephalopathy. The other name by which this is called is the steroid responsive encephalopathy, which is associated with autoimmune thyroiditis. And another general term which is used for it is non-vasculitic autoimmune meningoencephalitis. And we all know that this is associated with elevated anti-thyroid antibody titers. But the criteria, the 3 criteria that have to be met, that it has to be the memory deficits, the altered mental status, or the psychiatric symptoms have to be less than 3 months, friends. The fourth question which we had was on the black thyroid. The black thyroid is seen with prolonged therapy with tetracycline antibiotics, antidepressants, and lithium also, except ciprofloxacin. What is interesting about this entity is that it can be seen with as short a period as 14 days. Now, this becomes very relevant with us at this point of time, because with the rampant use of tetracycline derivatives in COVID, this is being increasingly reported. Pigment accumulation actually occurs in the thyroid follicular cells and colloid. Minocycline actually is a competitive inhibitor of thyroperoxidase, and this pigment deposition occurs because of the oxidation interaction between thyroid peroxidase and the drug. And that's the reason why we thought that this would be an interesting question out here. When you look at this picture, this is a microscopic picture of a thyroid. The right answer is diffuse thyroid lipomatosis. Over here, you would realize that there is extensive infiltration of thyroid. These are mature adipose cells, and that's the reason we are saying diffuse lipomatosis. This can rarely result in a diffuse goiter. The patient may not have too many other symptoms, But what is interesting is that when you do a cytology, you would actually have droplets of fat within the sample. And there's extensive replacement of the thyroid follicles by fatty infiltration. The question 6, which we had over here, which is actually a very simple question because we do deal with this at all times in clinical practice, in which all the other USG findings are consistent with malignancy, except that we all know when you're talking in terms of a thyroid nodule, you need it to be taller than wider in shape. And that is the reason why the answer would be wider than taller in shape. Now, which cancer was downgraded to a non-cancerous encapsulated follicular variant of papillary thyroid carcinoma? It was a non-invasive follicular thyroid neoplasm with papillary-like nuclear features, or the short form of NIFTP. And this happened because it was believed that these tumors do not grow or really spread. A diagnosis of a malignancy has a lot of psychological stress for the patients. We all understand, we talk about when we say thyroid malignancies are the simplest malignancies to have. And we all have heard all those statements about that, if you had to have a malignancy, it could be a thyroid. But we all know that the moment you hear a diagnosis of malignancy, it can be very devastating. And the reason this was downgraded, because what it was seen that these patients could actually be treated like as if they had a benign lesion. And these patients may not need a completion thyroidectomy, they may not need radioactive iodine therapy, less invasive treatment, maybe just a lobectomy would do the job for us. And that is the reason why it was downgraded, so that entire absolutely aggressive therapy as well as diagnosis was not alluded to. The answer to the 8th question is, as far as MCT8 deficiency, which was the most common movement disorder. The most common disorder is hypokinesia, though conventionally it is believed that dystonia is the most common disorder, but it is generally mild to moderate. What is actually more common is hypokinesia, which is seen in the majority of the patients. The question 9, as to recurrent thyroiditis. Recurrent thyroiditis, actually, we all know is by itself a rare entity, but even in this rare situation, it is seen more with renal thyroiditis and thyroid amyloidosis, followed by silent thyroiditis. When you look at hamburger thyrotoxicosis, there are only frankly case reports, because this occurs because of consumption of beef, which is contaminated with bovine thyroid gland. And this was actually a phenomenon which was seen in a single patient who had recurrent episodes of this problem over 11 years. So this is the order in which you would see these patients. As far as the last question is concerned, after a first episode of postpartum thyroiditis, a very, very simple and straightforward answer actually. The chances of recurrence is 70% in the women who are TPO antibody positive. And that's the reason why we need to have a very, very high index of suspicion when we are seeing these patients, when they give us a history of postpartum thyroiditis. In the subsequent pregnancy, we need to understand if the antibody positive, there's a very, very high chance of recurrence of almost 70%. Thank you very, very much for your patient listening.
Thank you so much, ma'am.
Thank you, ma'am.
Thank you so much, ma'am.
Most welcome.
Thank you, ma'am, for discussing the answers. I now request you to announce the winners. Asmita, can you display the winners, please?
Okay, so that's great. The quiz winners are Dr. Nanda, Dr. Lakshmi, and Dr. Nikita Shri Ramaneni. Big congratulations to all three of you all. And I think it's an absolutely women team out there. So big congratulations.
So actually, there are some people who have not been able to answer. I don't know, every time there is some problem, I don't know. We try to give the quiz rules also. Anyway, yeah, so over to you, Doctor.
There are a few questions which have come in the chat box.
Yeah.
I'll request Dr. Amit and Dr. Vikram to please take on these questions. The first question is, while deciding the thyroxine dose in pregnancy, body weight means ideal body weight or the actual body weight?
Sir, as per the, can you hear me, sir?
Yeah, Dr. Amit, please.
Yeah. As per the guidelines, it has mentioned that pre-pregnancy weight is to be considered when considering the dose of thyroid hormone in pregnancy.
Okay. It is actually the ideal body weight rather than the actual body weight. The second question is, a pregnant female having isolated increase in free T4 but normal TSH and free T3 has increase in only free T4 levels. What would you do in this case?
Am I audible, sir?
Yeah, you are audible.
Yes.
So, as I can hear the question, only the free T4 is elevated.
Yeah.
And the T3, TSH are normal in pregnancy.
Yes.
As I brought out during that slide, sir, the free T4 might transiently rise, especially in the first trimester. If the patient does not have any thyrotoxic symptoms, you can easily follow them up with frequent about another thyroid function test, say about 1 to 2 weeks later. And invariably in patients who have only free T4 elevated with normal T3 and TSH, generally they turn out to be only a transient free T elevation in pregnancy.
Okay. The next question is, how do you rule out carcinoma thyroid? Any specific sign which may be present?
Carcinoma thyroid, sir?
How do you rule out carcinoma thyroid? Any specific sign that may be present?
Specific sign, sir, they usually present with hoarseness, difficulty in swallowing, pain in neck. They might have one or multiple lymph nodes in the neck. Pemberton sign is one which I can think of as a specific sign. Which
any hard consistency. If it is hard, Pemberton sign is positive. It is more likely.
Pemberton is though it is not specific
thyroid.
for CA thyroid, it can also happen with lung carcinoma, lymphomas, thymomas, and even aortic aneurysm can present with Pemberton sign. So it is not specific.
Yeah.
But yes, because of thoracic inlet because of the thoracic inlet obstruction, there can be compression of the jugular veins resulting in a Pemberton.
The another question which has come up is the patient previously on levothyroxine or antithyroid medications, now diagnosed with pregnancy. What dose changes need to be done according to the trimester and TSH, free T3 and free T4 levels?
Sir, as I mentioned earlier, in case patient was already on levothyroxine and present in the first trimester, we have to increase the dose by 20 to 30% of levothyroxine dose spread over a week time. And we have to monitor every 4 weekly till 20 weeks of gestation. Followed that, we have to follow at 38 weeks of gestation. In this, we have to ensure that the TSH remains in the pregnancy specific range if it is for the local population. If not available in first trimester, TSH should be less than 2.5, and in second and third trimester, it should be less than 3. And the lower limit is 0.1, 0.2, and 0.3 micro international units per ml for TSH as per the trimester. As far as the Graves' disease patients who is on antithyroid medications comes with pregnancy positivity, ideally he should be prior controlled, well controlled, and planned pregnancy. But if he comes, we can in first trimester switch over him to propyl thiouracil. And the dose of propyl thiouracil is calculated almost 10 times that of antithyroid carbimazole drug. So accordingly, we have to give it in a 2 to 3 doses split over a day period. And here we have to monitor the patient in such a way that by every 4 weekly, the 3T4 levels remains up the upper normal range of the trimester specific range. And if the pre-pregnancy dose of carbimazole, if it is less than 20 milligram per day, then even in first trimester, we can skip the antithyroid drugs and monitor if there is control of the drug, control of the Graves' disease or not, because we have to maintain the patient in slightly in a subclinical hyperthyroid state during the time of pregnancy.
So essentially, the aim of treatment in Graves' disease is to maintain maternal free T4 at or just above the upper limit of normal.
Thank you, Dr. Amit. Thank you, Dr. Shekhawat.
So
there's one more in the chat box, like from Dr. Sandeep Kumar. Why hyperthyroidism patient on treatment, the thyroid function tests normal, has developed hepatitis. Viral markers are negative. Alcohol intake 3 to 4 units a week. Patient stopped carbimazole 3 weeks ago. And the thyroid profile is normal.
Ma'am, liver failure in the setting of pregnancy, where the patient has already left antithyroid drug, is it what?
Yeah, 3 to 4 weeks, no carbimazole, thyroid functions normal.
You can have multiple differentials there, ma'am. Acute fatty liver of pregnancy, even intrahepatic cholestasis have been documented. In fact, severe preeclampsia can also cause thyroid liver dysfunction, HELP syndrome, and certain very rare viruses like EB virus hepatitis, EB virus related hepatitis, and in very rare cases, herpes simplex can also cause hepatitis in pregnancy. So these
Dr.
are the
Vikram, can we ascribe this to carbimazole or to Graves' disease per se?
So I believe if you have already stopped
for 3 weeks, already
for 3 weeks, so I don't think that we can account for it. And Graves' disease, you must have already, you would have stopped antithyroid drugs only when your Graves' disease would have been controlled.
Yeah, the thyroid profile is normal right now, according to the description.
So unless the Graves' disease has a relapse, only 3 weeks is too short a duration, as Madam pointed out, the thyroid function tests are normal. So I don't think we can attribute it to Graves' disease or carbimazole. Acute fatty liver of pregnancy, intrahepatic cholestasis, severe preeclampsia, HELP syndrome, and rarely EB virus related hepatitis. These are the things that you can think.
And the patient is not pregnant, viral markers negative. So this is what Sandeep is writing. So anyway, you have discussed all the differential possibilities of hepatitis per se. I think the last question is,
do you advise iodized salt in hyperthyroidism?
Yes, absolutely. Dr. Srinivas wants to know that.
The guidelines don't recommend giving iodized salt to patients of hyperthyroidism.
Okay, we should tell the patient that the patient should not take iodized salt.
Yeah, that you should not be advising it to.
Okay. Thank you, Dr. Shekhawat. Ma'am, we have finished with the questions, ma'am. Over to you, ma'am.
Gandhi.
Yes, ma'am. So thank you, Dr. Naresh sir, for chairing the session. Thank you, Dr. Vikram sir and Dr. Amit sir for the dialogue on thyroid disorders in pregnancy. I would like to thank Dr. Sheila ma'am for the interesting questions for the quiz. And thanks to Dr. Amrish Mittal sir for attending this program and gracing the program and for the very explicit talk. I would like to thank the IT team for coordinating the session. So for the next session, we have Dr. Rakesh Sahai sir as the chairperson with two case presentations. The first by Osmania Medical College and the second by Apollo Indraprastha Hospital, New Delhi. They are moderated by Dr. C.M. Batra sir and Dr. Vaishali Deshmukh ma'am respectively. And the quiz will be conducted by Dr. Altamas Sheikh sir. So I request everyone's participation for the next session. So before we conclude, I request Dr. Sarita Bajaj madam and Dr. Pramila Kalra madam to say a few words.
Pramila.
Yeah, I think Gandhi has told everything. So it was really a nice thing, but only thing is we know that thyroid disorders in pregnancy is a very controversial topic. There are still a lot of debatable things which we keep on debating, and the cutoffs for treatment in hypothyroidism in pregnancy in subclinical range is still a debate between the 2.5 to 4 range. And that's a big debatable topic. So we need one more session on that to discuss about that. And also we discussed a lot of cases about how to approach a case. That's very important. And regarding the use of the iodine supplementation, that also is like, because our population, we still know that there are a category of people who are replete or over iodized, we can say, but there is still a category of people who are still iodine deficient in our country. So we have different areas where still iodine deficiency to some extent is prevalent because of many factors. So I think that again is one topic which will need one more session to discuss. And the quiz by Dr. Shaila was excellent. I think we had a nice insight into many things. And every time I think we learn with the quiz. All of us learn new things. I especially learned many things from the quiz. And not to forget, Dr. Amrish Mittal sir's talk on bone was fantastic. And I think a lot of insights again on thyroid and bone. So I hand over to Sarita Bajaj ma'am again for the final vote of thanks.
Thank you. So I think Amrish had to leave. He had a call at 9:30. So he has, it would have been nice if he'd been right now with us. And we could have thanked him. But I think his talk was absolutely brilliant. A topic which we have not covered earlier. We have addressed other issues, but that thyroid and bone had not ever been covered, at least not in thyroid clinics so far. Agreed, Pramila. Yes, we do need, there's still many more questions, and more questions are still coming into the chat box. So we can have, I think, a separate session only on thyroid disorders in pregnancy, maybe like a panel discussion, where we address all the questions, like the frequently asked ones. I think that's an excellent idea. So thank you, Naresh, for chairing it. And I can understand that Vikram is traveling, so he had a lot of issues with connectivity. But finally, I think both the presentations, Amit and Vikram, thank you. Thank you very much for being able to join us. And of course, Pramila, it's a pleasure to have you with us always. Arun must be there, Minnie. Again, she's there, and our wonderful reporter, Ganavi. I hope you're feeling better. She's not been well for the last 1 week. Shaila, the quiz, I'm glad you worked hard for it, but there, you can see the result for yourself. So I think we all enjoyed the quiz, and she's absolutely right. It's a two-way learning. And we also try to promote our journal, the Thyroid Research and Practice, and we have questions. We've taken questions from there as well. Congratulations to Dr. Nanda, Lakshmi, and Nikita, the winners of the quiz. And from the digital team, thanks to Ashmita and Priyanka. Thank you. Thank you very much.
Thank you, ma'am.
Very good night. Good night to all of you.
Good night, everybody. Thank you very much.
Good night, everyone. Bye.
Thank you.
Thank you, ma'am. Good night, everyone.